Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the managing editor and CEO of BBC Exhibit Hall. And I'd like to welcome you all to today's live webinar, which is hosted by DataGen, and it is called Unpacking the Mandatory CMS Model. Overcome new rules and challenges. So I'm excited to hear from these ladies today, which I'll introduce momentarily. There's a lot of good information here that I think you all will really enjoy. A few items of note before we get started, however. Everyone has listened or has joined today in listen only mode. So this is a traditional webinar format. You don't need to worry about turning off your microphone or your camera. That's been done for you. And even though we can't see you or hear you, we want to hear from you. So we're going to have a time for some Q&A towards the end. And at that point, if you have a question at any time, actually during the presentation, you can ask it using, you have a control module as an attendee, and you have a place for questions there. So drop your question there at any point, and we're going to get to as many as we can today during the allotted time. If for some reason we're not able to get to yours, don't worry. Someone will reach out via email afterwards and make sure that we answer your questions. But we're going to get to as many as we can. Finally, the session today is being recorded. So what's going to happen is about an hour or so after we conclude, you'll receive an email, and there'll be a link to the recording as well as to where you can download the slides from today's presentation. And that way you can review it at your leisure or share it with colleagues and friends. We hope that you do. Okay, well, without further ado, wanted to introduce our speakers today. First of all, we have Ms. Erin Hahn, and she is the lead policy analyst, value-based care and quality at the Association of American Medical Colleges. And then we also have Alyssa Dahl, and she is the VP of Advanced Analytics with DataGen. So welcome, ladies.
Thank you for the introduction, Garrett. Good afternoon and good morning to everyone who has joined our webinar today. At DataGen and AAMC, we are very excited to talk about CMS's newest mandatory episode-based payment model, which is now referred to as TEAM. We hope that we can provide you with some more depth into TEAM and how Medicare has come to this point with episode-based payment models. We'll review some of the model specifications, highlight what we think works well and not so well in the model, and then we will dig into some key challenges for hospitals and preparation strategies to overcome them. For a little bit of background, DataGen was founded over 25 years ago and is a subsidiary of the Healthcare Association of New York State. DataGen offers applications for community health needs assessments, legislative and litigation trackers, and culture safety surveys. We are an NCQA recognition facilitator for patient-centered medical home, and we also offer medical claims analysis for Medicare's Part A fee-for-service programs and the Centers for Medicare and Medicaid Innovations value-based payment programs. Our analytics and consulting services extend to organizations of all shapes and sizes across the country.
To provide a little bit of information on the Association of American Medical Colleges, we are a nonprofit association that's dedicated to improving the health of people everywhere through medical education, healthcare, medical research, and community collaborations. Our members consist of 157 US MD medical schools, 12 Canadian medical schools, approximately 400 academic health systems and teaching hospitals, which also includes the Department of Veterans Affairs medical centers, and more than 70 academic societies. Our hospitals make up 5% of all inpatient hospitals in the US. However, we account for 25% of all hospital inpatient days, 22% of all Medicare inpatient days, 28% of all Medicaid inpatient days, and 32% of all charity care costs. All of that to say that while we may be small in numbers, we do actually represent a significant portion of the US patient population. And on the next slide, I'll get into a little bit more information on how we work together now that you have some background on the AAMC and DataGen. So the AAMC hosts multiple collaboratives for academic health systems that are participating in value-based care models, and that is really where we overlap in our work. So DataGen really helps us with policy and implementation support, helping our members understand what models are appropriate for them based on their data. data analytics and benchmarking once they are part of programs, so looking at their own claims level data as well as benchmarking against other academic health systems. Shared learning amongst academic health systems, so we host regular webinars and DataGen provides ad hoc analyses for these webinars. And then lastly, advocacy to CMS. So we frequently advocate both formally and informally to CMS, and that is extremely backed by data. So the data that we get from DataGen is extremely helpful in how we advocate to CMS as well. And we're going to turn it back to Garrett now for a polling question.
All right, we are going to have an audience polling question, so you get to play along at home. All right, so I'm going to pull up on your screen a question here, and you should see it momentarily, excuse me. All right, and this is what aspect of the new CMS TEAM model are you most concerned about? If you had to choose one, and this is participation requirements, payment methodology, quality measure strategy, organizational preparedness, clinical engagement. I know you're all thinking, well, these are all important. But if you were in a corner and had to choose one, what would be your choice? We've still got answers rolling in here. And by the way, these are all anonymous, and we're going to be showing the results here shortly, so you can see kind of where you stack among your colleagues. And still have some folks answering, but it looks like most of the results have come in. So I'm just going to give it another 5 long seconds here, and we'll close it out. 4, 3, 2, 1, and a couple people. All right, here we go. I'm going to go ahead and close it and share the results. All right, Alyssa, are you able to see?
Yes, I can see the results. So it looks like 72% of our participants voted. The number one reason, or I should say aspect that organizations are most concerned about is organizational preparedness. 38% of respondents said that. That's then followed by the payment methodology and the quality measure strategy. And these are some of the things that we're going to comment on throughout the presentation and hopefully provide some helpful information for hospitals that will be required to participate in this model.
All right, so I'm going to close it back down and then turn it back over to you.
Great, thank you, Garrett. We're now going to shift gears to episode-based payment models and bundled payments to level set before getting into the details on TEAM. So just to get at all of the same level for some definitional aspects of the model and what we're going to be talking about, an episode of care is a patient's entire treatment for an illness or condition, including all services provided to treat a clinical condition or procedure. An event happens that triggers the episode. The patient goes on to receive treatment and services, and then the episode of care will end after a predetermined period of time. A bundled payment is when a single price is created to represent the full spectrum of services during an episode of care. In traditional, acute-based bundled payment models, this bundled payment will encapsulate expenditures for the inpatient admission, post-acute care, readmissions, and other Part B services like labs and imaging. Payments on facility claims and professional claims will all be included. In many of the early Medicare episode-based payment models, CMS would look at the average baseline period Medicare episode spend and would reduce it by a small percentage to incentivize or ensure savings. That would create the episode target price. This was a very simple pricing strategy used in the past. Setting target prices happens to be much more complicated in TEAM and other more recent models. If we just look roughly at the last 10 to 11 years, the rows of this table represent the episode-based payment models that have come out of CMS. There is one earlier Innovation Center episode model called the ACE program, which I have not displayed. Most of these models have been voluntary. Very few, like CJR, the Comprehensive Care for Joint Replacements model, has been mandatory. An asterisk in this table indicates the models that were designed to be mandatory. You'll notice 2 big red lines crossing out 2 models on this table. These are models that were proposed as mandatory and went through the rulemaking process, but were canceled prior to going live. These cancellations resulted from a change in administration for one and an act of Congress for the other. You'll see in the current year, 2024, there are several models that are still in play. CJR, which is the original mandatory model for lower extremity joint replacements, will be live through the end of this year. BPCI Advanced is a voluntary model for 34 clinical episode categories and will end next year. Last, the Enhancing Oncology model is also live right now and only recently began earlier this year. With that backdrop of the former models, the Transforming Episode Accountability model, otherwise known as TEAM, is CMS's newest mandatory episode-based payment model, which was recently finalized in the federal fiscal year 2025 Inpatient Prospective Payment System final rule. TEAM, in some ways, is the natural successor to CJR and will pick up after CJR's final performance year has been reconciled. In many instances, CMS adopted the blueprint of CJR for TEAM as a starting point and then expanded and enhanced the model in certain areas. We don't yet know if there will be another voluntary bundled payment model as an option for hospitals not selected for TEAM when the BPCI Advanced model ends at the end of next year. With that being said, Erin is now going to jump in and go through some of TEAM specifications.
Thank you, Alyssa. So to provide some high-level details on the TEAM model, TEAM is a mandatory episodic payment model. It includes 30-day episodes for 5 surgical procedures. Those are coronary artery bypass graft, lower extremity joint replacement, major bowel procedure, surgical hip or femur fracture treatment, and spinal fusion. The model is scheduled to run from January 2026 through December of 2030. To be eligible to participate in this model, you need to be an acute care hospital that's located in one of the 188 CBSAs that have been selected for mandatory participation. CMS has also decided to create a one-time opt-in for voluntary participation. This is only available to current participants in BPCI Advanced and CJR, so they can extend the work that they are doing in value-based care. To voluntarily opt into the model, you'll need to let CMS know by January of 2025. Additionally, once you voluntarily opt in, you are considered a mandatory participant. There is no way to terminate your participation, and you will be required to stay in the model for the full duration. The patients that are included in this model are Medicare beneficiaries with Part A and B coverage. This does exclude ESRD beneficiaries. There is a discount factor that is applied. So this is sort of a percent that is taken off the top if you see savings, and that is savings to Medicare. So that way Medicare can see savings in this model as well. A 1.5% discount factor will be used for coronary artery bypass graft as well as major bowel procedures, and a 2% discount factor will be used for orthopedic episodes. There are also 6 quality measures that are implemented in this model, and we'll get into more detail on those a little further in today's presentation. But on the next slide, I want to talk a little bit about the mandatory status of this model. So it is mandatory. In the proposed rule, CMS included 800 possible CBSAs, that 25% of them would be selected. So DataGen created this wonderful map here that looked at sampling and the probability of being chosen to participate in this model. And on the next slide, you can see what the final choices were for CBSAs from CMS. So CMS ultimately chose 188 CBSAs, which incorporated 741 hospitals. A full list of those hospitals is available on the TEAM website for CMS. So if you're still wondering if this includes you, I do encourage you to go check out that list. So now that we've talked a little bit about the mandatory participation, I want to talk about the different tracks in which you can participate. So track 1 is available to all TEAM participants starting in performance year 1 and only in performance year 1. This is an upside only track that has a 10% stop gain and a CQS adjustment percentage with a maximum of 10% for positive reconciliation amounts. What that means is that if you do see savings in the model, there is a potential to decrease those savings by up to 10% depending on your quality score. This specific track is also available to safety net providers for performance years 1 through 3. Since it's upside only, it's a way to help safety net providers get started in value-based care. For track 2, this is only available to safety net providers. And I will say that CMS uses the term safety net provider as sort of an umbrella term to encompass multiple different providers, such as safety net hospitals, rural hospitals, Medicare dependent hospitals, sole community hospitals, and essential access community hospitals. So this track will be available starting in performance year 2 and run through the end of the model. This one has a few guardrails in place, again, to help protect those safety net providers. So we can see that there is a stop gain, stop loss of only 5%, which is fairly minimal compared to the other tracks. There is also a CQS adjustment percentage of a maximum of 10% for positive reconciliation amounts and a maximum of 15% for negative reconciliation amounts. And what that means then is if you owe money to CMS, the amount you owe could potentially be adjusted downwards based on good quality. And then lastly, looking at track 3, this is available in all performance years to all team participants. This is sort of what we consider the increased risk and reward track for experienced providers. It has a higher stop gain, stop loss of 20% and a CQS adjustment of 10% for both positive and negative reconciliation amounts. So that matches more what we've seen in other models and has a sort of a higher level of risk and reward. On the next slide, I'm going to jump into some of the target price methodology. I do want to note that before we dive into this, we are still waiting for a lot of the methodological documents from CMS. We know that there is an interim final rule for IPPS currently with OMB, and there is potential that that will have some more team specifications. However, we can't promise that, but we are waiting for things to we are waiting for more things to see how this target price methodology would play out, such as how the provider and beneficiary level risk adjustment would apply. We also need information on how the regional prices will be calculated. So just note while looking at this that this is the information that is available now, but we are still waiting for more details. So in terms of how the target price is calculated, you start by creating a benchmark price that is calculated from the regional standardized baseline spending for the 3 years of the baseline. As noted by the purple boxes at the bottom of the screen, the baseline is weighted with the most recent year having the highest weight. That benchmark price is then multiplied by a prospective trend factor, and the prospective trend factor looks at the expected changes in overall spending patterns between the most recent year of the baseline year and the performance year, and this is ultimately compared to changes in spending that are seen between the first year of the baseline and the third year of the baseline. This is then multiplied by a prospective normalization factor. The normalization factor is to ensure that the risk adjustment does not inflate target prices overall. And this normalization factor has the potential to be adjusted upwards or downwards by 5%. And that could be applied retrospectively at the end of the performance year. This would then be multiplied by a discount factor. As I previously mentioned, the discount factor varies depending on the specific clinical episode, with a 1.5% discount factor for CABG and major bowel procedures and a 2% discount factor for those orthopedic episodes. And that ultimately is the calculation for getting the target price. Again, we are still missing some elements, but it is good to understand overall the different components that go into the target price. On the next slide, we'll dive a little bit into the quality measures and the quality approach for this model. So initially, CMS only announced 3 quality measures for this model: the hospital-wide all-cause readmission measure, the PSI 90 patient safety measure, and a patient-reported outcome measure that only applied to lower extremity joint replacement episodes. CMS did receive quite a few comments on their quality strategy and ultimately opted to introduce 3 more quality measures starting in performance year 2. So there are 2 hospital harm measures. One is a falls with injury measure, and the other is a post-operative respiratory failure measure. And then the third measure that is coming into play for performance year 2 would be a failure to rescue measure. And this measure will ultimately replace the PSI 90 following the precedents established in the IQR program. So moving on to the final elements of the model, just so you get an idea of some of the key concepts. In terms of health equity, CMS has incorporated a binary social risk adjustment where a patient would receive a score of either 0 or 1, depending on social risk. Identified as having social risk if they are duly eligible, Part D low-income subsidy recipients, or are located in an ADI beyond a certain threshold. Also, in terms of health equity, we see voluntary health equity plans as well as voluntary data collection around demographics and health-related social needs. In terms of the waivers for this model, there are 4 waivers. The first is a telehealth waiver, and this waives the originating site and geographic location requirements. A 3-day SNF waiver that waives the 3-day inpatient stay requirement for SNF coverage. A post-discharge home visit waiver, which they have opted to not waive the things that are traditionally waived, such as homebound status or incident to requirements. And lastly, an in-kind items and services waiver where you can provide services or items up to $1,000 per patient per episode, and anything exceeding $75 must be collected. They are also offering a voluntary decarbonization effort. So again, this is a voluntary effort, and by participating in this, you would sort of receive status as being a green hospital. Part of this is reporting on things like anesthetic gas use, which will be pulled using your purchase records, hospital emissions, which is pulled from Energy Star scores for hospitals. And the only thing that really requires direct reporting from hospitals would be the transportation metrics, in which hospitals would need to provide information on their vehicle fleet, gas use, and things of that nature. So that was just a very quick rundown of some of the key elements of the model. I'm going to turn it back to Alyssa now, and she will cover some of the methodological considerations.
Thank you, Erin. One of the things we really wanted to do in this webinar is put some thought into what works well in TEAM and what will be problematic beyond the mechanics of the model that are written into the final rule. When thinking about what works well, these are the 5 items that stand out. TEAM is laid out very similar to CMS's model structure that is currently being used in CJR's 3-year extension. We could tell that CMS was really trying to play it safe in how TEAM was proposed to make it through the rulemaking process, aligning with a mandatory model that is already in play, and then carefully choosing which new aspects to innovate with, like the expansion to 5 surgical episode categories instead of just 1. Hospitals that will have mandatory participation status for TEAM have over a year to prepare, at least 16 months from when the final rule is published. It's a lot more time than hospitals typically have with a voluntary episode-based payment model. Hospitals should be taking this seriously and doing their due diligence ahead of time. This means working on getting their staff educated and engaged, looking at data to understand how they are positioned for the model, revisiting protocols and workflows to identify opportunities for improvement, and understanding what resource constraints they have. When we talk about resource constraints, that can mean workforce for nursing and patient navigation, bandwidth of existing staff, and even technology. Fortunately, every hospital entering TEAM can enter the model at track 1 for performance year 1, meaning they will have no downside risk. A well-prepared hospital can already be putting into practice new workflows and other care coordination improvements before the model begins, and will face no financial penalty in the first performance year while still figuring things out. Each performance year will only be reconciled once, happening about 6 months after the performance year ends. Other models in the past would go through numerous true-ups as more claims run out would happen, dragging out final performance and payment changes for multiple years. And last, CMS is implementing risk adjustment for provider, beneficiary, and social factors into the model's payment methodology. It's a very complicated task to control for that many factors that can impact an episode's payment while still trying to aim for simplicity and predictability. Despite what was done well with TEAM's proposal and final rule, there are a few areas where the model could have been designed better, and I'll go into each of these with a little more depth. On the topic of participants, a few items stand out. First, TEAM doesn't yet have a low volume policy for participating hospitals. In the proposed rule, CMS wanted to set the low volume threshold to 30 episodes across all 5 episode categories and the 3-year baseline period in total. If a hospital only has 10 episodes per year across 5 different procedures, they're going to experience a lot of random variation in their episode expenditures and can have erratic and unpredictable reconciliation results. We anticipate CMS finalizing a low volume policy sometime in the next year through the rulemaking process. The next issue for participants relates to the definition around what is a rural hospital, since rural hospitals can be in the model under Track 2, and in many prior models, rural hospitals were entirely carved out. A hospital must be located in a rural area or in a rural census tract to be considered rural as of the final rule. And last, many hospitals with bundled payment experience were happy to see that there was an option to voluntarily opt into TEAM so that they can continue their work on episode-based care and don't lose momentum when their current models expire. Voluntary opt-in is an option for hospitals that participate in CJR or BPCIA until the end of those models. They will need to make their decision to opt in very soon in January 2025 in the absence of any team-specific baseline data. Opting in carries a strict commitment. These hospitals will be at risk for all 5 episode categories and cannot drop out of the model. The next problematic area in TEAM has to do with the payment methodology. While the industry is very happy to see the effort put into expanding the risk adjustment strategy, some aspects of it, like the look-back period for comorbidities, are not final. More rulemaking is anticipated to finalize those decisions. In addition to that, the actual risk adjustment coefficients or multipliers are still unknown, which means participants cannot fully estimate what their target prices will be. It is unlikely we will see them until Q4 of 2025, since 2024 is part of the baseline period and will need to be complete for CMS to run those episodes through their price prediction models. The last piece of the target price that DataGen has a lot of concern about is the normalization factor. This is a factor that is implemented so that the risk adjustment factors do not change the national non-adjusted average target price. We've seen this normalization factor play out once so far in CJR, and we're shocked by how much it eliminated the benefits of risk adjustment. The next aspect of TEAM that hospitals need to understand is that an episode needs to have sufficient actionable Medicare cost that can be targeted by care management teams in order to produce reductions in the overall episode cost that exceed the CMS discount. DataGen considers actionable costs to be all Medicare payments in the post-anchor time period that are not for professional services. Though these actionable costs can be thought of as mathematical opportunity, hospitals will need to determine what is clinically feasible and appropriate for their patients. Different strategies to reduce Medicare spend will be appropriate for certain types of post-acute care and will vary by episode category. The last aspect of the TEAM model I'll comment on is the quality measurement strategy. A lot of it comes down to the measure selected and in some cases the population included in the measure. The inclusion of measures like PSI 90 and the hospital-wide readmissions measure mean that hospitals have the chance of experiencing duplicative payment penalties since these measures are already captured in other pay-for-performance programs. In addition, these measures will be calculated for the hospital's entire Medicare population, not just the beneficiaries who triggered episodes in TEAM. During the comment period, some stakeholders suggested the importance of hospital perioperative services on episode outcomes and recommended measures with a focus on surgical-related prehabilitation services. Inclusion of these types of measures could be more impactful when assessing quality of care in TEAM in the future. CMS and commenters stress the importance of patient-reported outcomes. However, there are limited episode-specific patient-reported outcome measures to choose from, and these measures come with a high reporting burden. Patient-reported outcomes will only be collected for total hip and knee replacement episodes, aligning with other Medicare quality reporting initiatives. Hospitals newly adapting to collecting and reporting patient-reported outcomes will need to consider what infrastructure and process development they need to undertake to successfully collect and report this information. We'll now transition into a discussion on challenges and strategies to prepare, led by Erin.
Thanks, Alyssa. So we stopped to consider some of the big challenges that you will all be thinking about over the next year and a half as you prepare for the models. So some of the big things that we're thinking about include personnel, operations, technology, analytics, and advocacy. And these are all aspects that we'll get into more detail on in this section. So starting with personnel, we think it's important to focus on building your team. One of the things that's really essential usually for voluntary models is having leadership buy-in, so that way you know you have the staff and resources available to succeed in this model. Unfortunately, because it's a mandatory model, that may not be the case. You may not be able to secure that leadership buy-in the same way you would for a voluntary model, but hopefully, given that it is mandatory, that your leadership will see the benefit of providing staff and resources for this type of work. Other things to consider would be having a multidisciplinary care team of professionals that will need to collaborate in order to standardize and execute care delivery. Successful implementation of alternative payment models really does require coordination between operational roles, clinicians, as well as your information technology professionals. In terms of that multidisciplinary care team, though, thinking first about your clinicians, one thing that we always suggest is having a clinical champion. A clinical champion is somebody who will play a critical role in securing buy-in from other clinicians and from leadership. They'll also play a significant role in care redesign activities that may need to take place. Next, looking at care managers and nurse navigators. So these are people who can identify your high-risk patients, whether that's due to HCCs, health-related social needs, it could be high readmissions or ED use, but however you choose to identify those high-risk patients, these are people who can identify and follow through with them. So they can check in with them post-discharge, check in with them during care transitions. They can provide relevant information on what setting is appropriate to go to at what time. So maybe some situations it's just a visit to your primary care provider versus an ED visit. So these are people who can really help direct that high-risk patient population. Additionally, thinking about analysts in your team. So coding and billing, I'm going to start there. So one thing that we see quite frequently is services not being captured appropriately by coding and billing. An example I can give of that is in BBCI Advanced with Advanced Care Plan Quality Measure. This is a measure that I think most hospitals are participating in and are doing on a regular basis. However, they may not be coding or billing appropriately, and therefore a lot of the times the Advanced Care Plan doesn't get captured and hospitals aren't rewarded for the work they're doing there. So thinking about how you code and how you bill to make sure that you are capturing the services that you are delivering that are appropriate for the model. Additionally, in terms of analytics, it's really important to have somebody looking at your data on a very regular basis. They can determine areas for improvement and track progress. A lot of these models, they have a lot more data than some people may be used to if they haven't participated in a value-based care model before. You have claims level data for the entire length of the episode, including post-acute care. You have quality data. So having somebody whose key responsibility it is to look at that data and determine areas for success and areas for improvement is really important to doing well in these programs. So moving next to look at operations or workflow. So some of the things that you need to start off with are just basic protocols. How do you identify which patients are in team? How do you notify your beneficiaries? Thinking about your waivers, which ones would be beneficial, making sure you understand how to initiate those waivers. Additionally, having that post-discharge follow-up with people like your care navigators or care managers or nurse navigators. Additionally, thinking about the service line and organizational resources. So that sort of goes back to that leadership buy-in. Do you have the staff, the resources, the funding necessary to work on these types of projects and to take on revamping of service lines and things along those lines? Also thinking about things like model-specific trainings, it is really important that the staff who are working on this program understand the intricacies of the program. So providing education to familiarize your staff with TEAM's requirements and specifications. This could include training sessions, workshops, or resources that help basically explain the intent of the model, specific program rules, as well as an individual's specific role in the implementation of that model. So involved staff members will also need to understand the surgical procedures as well as any care protocols that they will need to follow. We would also suggest that even if you have previous experience in alternative payment models, that you think about doing something similar in terms of training and education. All models are different, and you may have staff that are new that haven't previously worked on other models. And yeah, we would encourage you all to sort of lay that groundwork a year and a half in advance here to encourage people to really engage with the work with team. The next two areas here, I'm kind of going to skip over because I covered them on the previous slide, but I think it's really important to note that identifying high-risk patients and having a way of managing those patients, either through care managers or nurse navigators who can follow up, who can monitor during care transitions, is really important to ensuring good outcomes, but also decreasing things like readmissions and ED use. And then the last thing I wanted to touch on this slide as well would be establishing a post-acute care network. So it is really important that you are working with high quality, low cost post-acute care spaces. In addition to that, it's important to meet with them on a regular basis. I think our members that have been successful in their post-acute care space in the past have set up regular meetings with different SNFs or inpatient rehabs, and they talk through sort of the interventions that they are working on. They talk about the services that are provided and those types of things. So it's important to build out that network. Additionally, we get stuck in habits of doing the same sort of post-acute care that may be not clinically appropriate for our patients. And to give an example of that, we've worked with a hospital previously that used to send all their patients to inpatient rehab for joint replacement procedures. And that facility ultimately ended up having to be closed down due to an emergency. And they decided that they would start sending their patients to lower acuity post-acute care settings, which they thought would result in worse outcomes. And in fact, it actually had better outcomes because matching the acuity is important, but also they were finding that the inpatient rehab, because they were attached to the hospital, would often send patients back for readmission even when it was not clinically appropriate. So just making sure that you have a look at the appropriate acuity of the setting compared to your patients as well is extremely important in terms of seeing good outcomes. So moving to the next slide, we're going to have a look at the analysis resources. So it's really important as well to understand internal resources. Does your organization have data analysts on staff? Do they have the bandwidth to do monthly claims files from CMS and process that data? Does your technical team have the needed skills, the business intelligence tools, and time needed to evaluate the episodes of care? If you are a mandatory CBSA, you are selected to participate in this model, you're going to have to start thinking about your historic performance, analyzing your data for opportunities and things of that nature. So it's time to start thinking about whether or not you have the resources to do that in-house or if that's something that needs to be outsourced. And thankfully, you have a year and a half to do so. And thinking about the partnerships, so enlisting the support of data experts such as DataGen is really a wonderful thing to think about. We all have analysts that can help, but thinking about whether or not they have the extended knowledge that other groups do have. So thinking about DataGen, who, for instance, for us, has the policy knowledge, they're able to provide education and empowerment for our members as well. And so they understand from a policy perspective as well as just a data perspective. So having a partner that can help you really move forward is really important. And then moving next to reconciliation and thinking about how we prepare for that. So you do want to continuously analyze your data to be thinking about ways to identify potential losses and opportunities for improvement. You want to be thinking about your quality measure performance and Medicare costs across the continuum of care. As Alyssa mentioned earlier, there is only one reconciliation cycle per performance year. And so that means that you will be unable to receive your final reconciliation until over a year and a half out. And if you are implementing interventions without having the analytics and checking your data, there's potential that you have errors or have issues in the interventions that you're implementing that you won't see for a year and a half. So in order to course control or correct and fix any issues that may arise, it's really important to continuously watch that data. So we do encourage you setting up regular meetings with your analysts or having regular access to the data, whatever is working for you all. But basically, it's really important to ensure that you're following that data, that you're following your progress, and that you're not just waiting a year and a half to find out how you did. So lastly, I do want to touch on advocacy. So on this slide, we sort of outlined the different ways that we advocate, as well as some of the things that we've advocated for previously. But the main point about this is that it's important to continuously advocate back to CMS about the things that are working well and the things that aren't working so well. On those lines, having data is really beneficial in proving your point as well. It's easy to go to CMS and say we're having issues with this, but having the data to demonstrate how and why that issue exists really helps CMS address it. If they don't have a way of addressing it, if they don't understand what the issue is, it's really hard to alleviate the problem. And so having that data really helps CMS to drive change as well. So that was just a very quick rundown of some of the things that we can do to prepare. I'm going to turn it back to Alyssa now.
Okay, so as we conclude this presentation, Erin and I want to share a little bit with you all of how DataGen and AAMC are positioned to support hospitals in TEAM. As you know, hospitals that will be participating in TEAM have over 1 year to prepare for when the model goes live. Calendar year 2024 is going to be the final year in the TEAM baseline period, so we do not expect CMS to release baseline data to participants until Q4 of 2025. For this reason, DataGen has 2 services to support hospitals that will be in TEAM. The first service is DataGen's TEAM Shadow Bundle Opportunity Analysis. DataGen simulates TEAM episodes of care using claims data from the National Medicare Standard Analytic files, triggering every potential episode across the country. Hospitals can use this data now to understand how they are positioned for the TEAM model, so that they may begin to plan on how to improve care delivery and coordination for these episodes of care. The second service is DataGen's TEAM Performance Data Monitoring and Reconciliation Validation Service. This is a subscription where hospitals who are live in the TEAM model will utilize the episodes and claims files that CMS distributes as part of your participation. Hospitals use this analysis to monitor their ongoing performance in the model, plan care interventions, and assess results. DataGen also supports hospitals when reconciliation results are released, helping them understand what drove their performance and validating that CMS performed calculations in the way that they were described in the TEAM specifications. If errors are found, DataGen provides hospitals with a report of potential issues they can contest. Why should hospitals consider analyzing shadow bundles to prepare for TEAM? There are numerous benefits. Hospitals can assess utilization and performance within their TEAM procedure-specific bundles. Shadow bundle data can be used to identify issues and monitor internal quality improvement projects, can allow hospitals to better understand their costs to Medicare, and may present opportunities for the standardization of care patterns. Shadow bundle data can also provide hospitals with a deeper view of specialist performance and can be used as a tool to engage with specialists. Hospitals can consider incentives like gain sharing as a strategy to align clinicians or other downstream care providers. If you are a hospital that will be participating in TEAM, I urge you to consider the resources that model-specific collaboratives can offer. The AAMC hosts collaboratives for specific Medicare value-based care models like TEAM that are available to all hospitals and providers affiliated with an academic health system. Through the collaborative, AAMC offers learning events to educate hospitals on different topics related to the model and best practices, peer-to-peer collaboration to share challenges, successes, and opportunities for improvement. DataGen's analytics platform is included, allowing hospitals to conduct advanced analyses, benchmark performance, and simulate what-if scenarios. And together, we also provide one-on-one data reviews and consultations so that we can help you understand your performance in the context of the program and empower members to communicate and act on their data. At this point, we're now going to move into our question and answer session, which Garrett is going to help us facilitate.
Okay, well, first of all, wow, this was a fantastic presentation. There's a lot there. It's a lot of weeds, as I'm sure you all know. But don't worry, we're going to be sharing with you the recording and the slides, and you'll be able to ask your questions. But if you have, speaking of questions, if you have a question now, go ahead and drop it into your question. There's a place for the questions in your module, and we're going to get to as many as we can. And we do have a big audience today, and there are a lot of questions. So in no particular order, let's go ahead and begin here. First question is this: what happens for hospitals at risk during the reconciliation process?
So I can take this one. So when it's time for CMS to conduct the reconciliation, and this will be about 6 months after the performance year ends, CMS is going to look at the total Medicare episode expenditures for the episodes that were initiated at your hospital. They're then going to finalize the target prices as well. So according to your hospital's patient case mix, you will have a target price that is generated. The trend factor and normalization factor will be updated for that performance year. And then CMS is also going to calculate your quality score and what your stop loss or stop gain thresholds are. When they compare actual expenditures to those target prices, one of two things will happen. If the episode expenditures are higher than the target price, then the hospital will owe a repayment to CMS. And if the hospital's expenditures are lower than the target price, then they will earn a performance-based payment. And one important thing to remember with the quality score is that if you have a positive reconciliation result, but poor quality, that can lower the savings that you will receive from Medicare. But on the other side, if you have a negative result where you will owe a repayment to CMS, having a strong quality score will actually reduce the amount that you would have to repay CMS. So that's ultimately what happens during reconciliation.
Wonderful. Next question here. How does CMS account for the cost of care being higher or lower in different markets across the country?
So one of the important things to remember, and if you recall the slide on the target price, CMS starts with standardized spending for those episodes. So standardization or neutralization, that means that CMS removes things like the wage index or payment penalties for programs like the readmissions reduction program. They take out all of those types of elements that impact how a specific provider in the country will be paid. And that is what they use to ultimately compare episode expenditures to the target prices. Then in reconciliation, when CMS actually calculates what the savings or repayment will be, they will then re-add the geographic factor to it. So then it is adjusted for what dollars are in that particular hospital's location.
All right, moving right along. The next question here is, will the QMs added in PY2 be in addition to PY1 measures or replace PY1 measures?
Erin, do you want to do this one?
Yeah, sure. So our understanding currently is that they will be added to the existing measures. We do know that the failure to rescue measure will replace the PSI 90. So that measure will be eliminated going into performance year 2, but the all-cause unplanned readmission measure, as well as the lower extremity joint replacement patient reported outcome measure, will also be implemented in performance year 2.
Wonderful. All right. Next question is, it says, I'm a provider organization with many providers doing included surgeries at mandated hospital participants. We're wondering how our organization fits into this model and how reimbursement to our providers might be affected, given that the hospital is the participant. Is anyone else in this same situation? Any insights?
Well, I'll just say that as the model is running, CMS will continue to pay all providers according to the fee-for-service payment system rules. So there is no change that happens in the actual billing. However, when reconciliation happens, it is the acute care hospital that will ultimately be financially accountable. Now, what some hospitals may do if they work with a physician group, that may not necessarily, and if they don't have those physicians necessarily employed on their staff, CMS allows for arrangements like gain sharing, so that there is a mechanism that is allowed for the hospitals to share those savings or also those penalties potentially, for good or bad performance in the model.
Wonderful. Next question here is, can you please redefine the episode payment actionable status?
So for DataGen, when we think about the costs that are actionable, we're looking at the costs that happen after the anchor procedure. So we're in the 30 days post-discharge. So what would be included? Any post-acute care, any readmissions, any Part B expenditures for things like labs and imaging. That's really all the care that you potentially have the ability to change. When you look at the episode spend, a majority of the episode spend is entirely composed of the DRG or the actual surgical procedure payment on the outpatient side. So unless you're talking about a short stay or a long stay, that payment is going to be static and is not something that providers can actually do anything to change. So that's what we mean by thinking about what is actionable versus what is inactionable or static in the episode.
Okay. Next question. Do you think there will be different regional target prices for inpatient versus outpatient major joint replacement, or one combined consolidated target price?
I do not believe that there is any distinction between inpatient and outpatient, and I believe the outpatient procedures are assigned the lowest acuity DRG payment in how those target prices are set. So these target prices are site neutral.
Okay. Next question here is, says, thank you for the presentation. Based on Pop Health VBC work, could the prospective trend and prospective normalization factors be negative? And additionally, is PY concurrent risk capture risk adjustment an option? Thank you.
So to think about the trend, the trend and the normalization. So typically it's not impossible for the trend factor to be negative. It tends to always be positive in the direction that dollars are heading. And I would say I would expect the normalization factor to have a negative impact on the target price. At least when we saw it in play for the CJR target prices, in performance year one, it brought the national average target price down by 14%. And it basically removes a lot of the value of the risk adjustments, unfortunately. So that is what I would anticipate, although I haven't seen what those factors will be for TEAM. CMS does commit to saying that the prospective factors will be released prior to performance year one, but we usually assume that's going to mean they'll be released in Q4 of 2025, which is right before performance year one. And I think there was a second part to that question.
Yeah, let me ask that part again. It says, additionally, is PY concurrent risk capture risk, I'm sorry, let me read this again. Additionally, is PY concurrent risk capture slash risk adjustment an option?
Well, what they will do for the performance year, your target price will ultimately reflect the patient case mix of the population that actually initiates episodes at your hospital. So you're not going to get a case mix adjustment that was based off of your baseline period, the baseline period, what your experience may have been. Your ultimate target prices are going to reflect the patients that you saw. And Erin, if you want to comment anything on any of that, feel free to jump in.
Erin is actually having a technical issue right now with her sound.
That's fine.
So no worries. She's panicking on her end, trying to get.
It's okay.
So she'll be back momentarily. I advise her to sign back out and sign back in. We're working live, folks. Um,
Mhm.
but we'll go along to the next question here in the interim. We have time for a few more. And again, if you have a question, go ahead and drop it in now. Uh, does the episode begin at the time of DC? DC. Discharge? I don't know. DC.
Um,
I don't know what DC stands for.
oh, at the time of discharge, so the 30-day time period that's added to the episode will, if it's an inpatient episode, it will begin upon that inpatient discharge date. And if it's a outpatient episode, it will start at the completion of that surgical procedure. So that's when the 30-day window begins.
Okay, great. Welcome back, Erin. Um, okay, next question here is, let's see. How does this model work with value-based purchasing model reimbursement in place for all organizations?
Erin, do you want to take this one or I can respond if not?
I think I would have to look into the details of VBP a little bit more, but I do know that there is overlap allowed between the models currently. There's overlap between team and almost all models, I believe. Alyssa, sorry, I think I'll let you take this one then.
Yeah, I would say all of the standard Medicare payment policy programs like value-based purchasing, the readmissions reduction program, the inpatient reporting quality system, all of those are in play because that's part of the standard IPPS payment system. Um, so this, when you think of a model like TEAM and really a lot of bundled payments, they sort of operate in this space where fee for service is still happening as is standard and expected. Um, and these models almost operate on like a halo. They're not actively changing the way that providers are billing and being paid in real time, but at the end of the period is when that reconciliation happens and the money exchange happens. So I don't think this model has any impact on value-based purchasing.
There's a second part of this question that they said also, is quality performance based on current performance baseline, or are we simply rewarded when we are better than the mean?
So for some of these quality measures, and I would have to look back more specifically into the rules, um, the there's going to be mismatch between the populations and also the years that are being followed. And that's happened in prior programs too. Something like patient reported outcomes, that's going to be very closely tied to the actual patients that triggered episodes because they have to be surveyed. Um, but I would not expect the same for things like PSI 90 and the readmissions measure, especially because we already know CMS isn't going to limit it just to the patients that triggered episodes in TEAM. They're going to be looking at the entire Medicare population.
Okay, we have time for one more question, given it's hopefully a quick answer here, and then we'll have to wrap up, unfortunately. And this last question is, how will COVID cases in the baseline data be addressed in 2026 target prices?
I don't recall any particular exclusions or even risk adjustment for COVID cases. In prior models, there has been control for COVID, especially in the beginning of the years. Either they had entirely taken those patients out, or in some
Mhm.
models they had a risk adjustment factor. Erin, I don't know if you recall anything. We'd have to go back and read the rule, but
Yeah,
um,
I don't recall seeing anything carved out for COVID like we've seen in previous models.
mhm.
Very
And that
good.
performance year baseline is 2022 through 2024. It's also going to be rebased every year and is going to move up. So the impact of COVID on utilization in the care system, while it was very big at the beginning of COVID, um, over time it will have less and less impact as things have gone back to, um, and those patterns have sort of evened out.
Gotcha. Well, unfortunately, we are out of time. So thank you both so much for a fantastic presentation. Obviously, there's a lot here, and you still may have questions. And if you do, we're going to give you the information to reach out here shortly. But as we wrap up, I wanted to encourage you all to head over to vbcexhibithall.com and check out the DataGen virtual exhibit booth there. And we're going to have a link in the slides that we share. There will be a link directly to it, and you can read up on them and what they're doing in space, and kind of really educate yourself on some of their resources, and of course reach out to them through there. And there's a lot of great resources also on vbcexhibithall.com in their library, where you can really educate yourself, other webinars and white papers and so on. So please come by and take a look. And then finally, if you would like to reach out directly to the DataGen team, to either of our speakers, Alyssa or Erin, their information is here. And again, this will be on the slides that we share. I wanted to thank you all so much for joining us, spending your afternoon with us. Thank you, Alyssa and Erin, for a fantastic presentation. We hope that you all have a wonderful rest of your day. Bye-bye now.